departments of Universidad Javeriana and Hospital San Ignacio, today with the collaboration of Pathology Department. It's an honor to introduce Dr. Sanjay Makopadway. Dr. Sanjay is the Director of Pulmonary Pathology Service at Cleveland Clinic in Ohio. He is the author of the renowned book Neoplastic Pulmonary Pathology, and he has published many papers in the field of lung pathology. Dr. Sanjay is also a pioneer in the use of social media for pathologists, and actually he is one of the most powerful pathologists on social media, according to the pathologist. Sanjay, welcome to this meeting. I know that you have a very busy September, so we appreciate a lot your time to share your experience with us. Today you have audience from Colombia, Ecuador, Spain as well, the United States, so we are ready to share this time with you.
Thank you very much, Jorge. Really appreciate it. Thank you for inviting me. You're very kind. Thank you also to Maria for helping me through this whole system to get me set up, for teaching me how to use the system, and for spending so much time with me beforehand. And thank you to Irene for helping me with the Spanish part of the slides, which is going to be sort of a surprise part of this talk. So I'm going to talk about COVID-19 pathology. So what have we learned from pathology specimens? This is my Twitter handle at @smlungpathguy. I post educational material related to lung on Twitter, and I'm the Director of Pulmonary Pathology at Cleveland Clinic. Uniquely, I think, among many people in the United States, I'm one of the few people that does only lung. So I don't do anything else. It's only lung, lung, lung all day long, lung, pleura, thymus. And my two colleagues that are in my department also do the same thing, and we have a very big volume and a very busy lung transplant service. So I'm going to try this a little bit in Spanish. Hopefully Irene will correct me, or Jorge will if I do something wrong. But this is COVID-19 que hemos aprendido de las muestras de patología. We're going to I just want to briefly mention that I have no disclosures during this talk. We are going to start with a question. I like to do that just to see where people are in the beginning. So Maria, this is your cue. So the first question is, pregunta uno de la encuesta. ¿Cuál de los siguientes opciones puede diagnosticar un patólogo? Option 1 is síndrome del distrés respiratorio agudo. Option number 2 is daño alveolar difuso, or DAD in English. Option 3 is tormenta de citocinas, or cytokine storm. And option 4 is disfunción endotelial, or endothelial dysfunction. So which of these four?
Well, the pool is open.
Yeah. Sorry, Maria, what did you say?
Sanjay, I was going to say that the pool is open and people can actually vote if they want. It's shown on the screen.
I'm seeing the responses right now.
We have 25 responses.
Excellent. How's the Spanish going so far, Maria? Is it reasonable?
It's amazing. It's really good.
Okay.
Yeah. Well, actually, we have 46 answers. I'm gonna give a little bit more time because we have more audience, and I will let you know. Sure. I will close the poll.
I'll wait.
Well, people are starting to vote. If you want to vote, I will close the poll in just a few seconds. So go ahead. Okay, I just closed the poll. We have 51 persons voting for option number 2, daño alveolar difuso. And one person actually voted for option number 4, disfunción endotelial. Okay.
Yeah, which is virtually unanimous. Almost everybody said the same thing, right? Almost everyone said diffuse alveolar damage, or daño alveolar difuso. And in fact, so I can go to the answer now, Maria, is that okay?
Yes, sure, you can go for the answer.
Okay, let's go. So the correct answer is la respuesta correcta es daño alveolar difuso. So all of you are correct. That is really the only one of these four things that can be diagnosed by a pathologist. The síndrome del distrés respiratorio agudo, so ARDS is not a pathologic diagnosis, so pathologists cannot diagnose ARDS. I included this because sometimes people say, are you seeing ARDS in the biopsy specimen? And that's an incorrect question because you cannot, there's no such thing as ARDS on pathology. There's only DAD on pathology. Similarly, a cytokine storm, people ask me, do you see findings consistent with a cytokine storm? But there's no such thing in pathology. So that's incorrect. You just cannot diagnose that. And endothelial dysfunction is not a pathologic diagnosis, although if you had damage to the endothelium or vasculitis involving the endothelium, that could be diagnosed by pathology, but not endothelial dysfunction. So you're all correct in your answers. So Maria, we'll go to the next one next, which is pregunta 2 de la encuesta. ¿Cuál de los siguientes se encuentra comúnmente en las autopsias de COVID-19? First choice, daño alveolar difuso. Second choice, inclusiones virales. Third choice, myocarditis. And your fourth choice is vasculitis. So which of these four is a common finding in COVID-19 autopsies?
Well, people are already voting.
Yeah, that's great.
Yeah, that's great. You're seeing actually the poll question.
And we're getting more of a spread this time than in the previous question. So more people are voting for other things too. I'm
getting better with this. Sorry, Sanjay.
That's great.
A technical support in progress.
No, I love this. I love the fact that there's a. I wonder if I move that over. No, it's on a different screen. It's going great, the polling function. I wondered that if we put this on the video, if people will be able to see how the responses are going.
Yeah, at the end on the video, everyone will see the answers and the polling questions. I made sure of that. So whenever you want, I can close the poll of the question if you're ready.
Yep.
Well, it's close. We have 48 answers for option number 1, 1 answer for option number 2, 2 people voted for option number 3, and 8 people voted for option number 4.
Yes, so the correct answer here is, let's go to the next screen. La respuesta correcta es daño alveolar difuso. So it's the same answer as last time. So if you think of what is the most common finding in COVID-19 autopsies, it is actually diffuse alveolar damage. The other things have been claimed, so viral inclusions have been claimed by several authors, but are not common in COVID-19. Myocarditis is a very controversial topic, but it is not common at all. In fact, some autopsy series don't have any myocarditis, and many autopsy series only have 1 or 2 cases out of fairly large series. And others are now guessing that the pathologically confirmed incidence of myocarditis is close to 15%, is definitely not high, so this is not common. And your fourth choice, which is vasculitis, yes, vasculitis has been claimed, but is extremely rare. It's mostly has been seen in the skin. And very rare other cases of vasculitis have been seen in COVID-19. So most cases of COVID-19 do not show any evidence of vasculitis in any organ. So we will start with the first part of this talk, which is Parte 1, COVID-19, daño alveolar difuso y síndrome del distrés respiratorio agudo. So DAD and ARDS. And I would like to explain what the relationship is between these things. So in COVID-19, the first time that we heard about DAD and ARDS was from this paper in Lancet by Zhu et al. This is from China, that came on early in the in the pandemic. And what it showed is that if patients with COVID-19 who are dying who are coming to the hospital in China, if they developed ARDS, they had a very high risk of death. And if they didn't develop ARDS, they had a relatively lower risk of death. And here are the numbers in this study by Zhu et al. So the total number of patients was 191. ARDS developed in 59 of those patients, which is 31%. And ARDS also developed in 59 had ARDS. Of those, 50 of them were non-survivors. In other words, 50 of them died. 50 of the 59 patients died who developed ARDS. There were only 9 survivors in that group. So of the 59 patients, 50 died and 9 survived. So ARDS was a very strong predictor of mortality in this series. Now, right after that, after we knew that ARDS was developing in COVID-19 patients, we since then have had a relentless increase in the number of cases globally. So now we have 25 million confirmed cases globally and 848,000 deaths by now. Can anybody guess by about April or so how many autopsy cases we knew of? So how much pathology was available by about April? Can anybody guess? Here's the answer. So by about end of February, we had about 3,000 deaths globally. By the beginning of April, we had more than 100,000 deaths globally. And how much pathology did we know about? We had 1 post-mortem biopsy from 1 patient. This was from China. So we were majorly lagging behind in pathology in terms of the knowledge of what was happening within the lungs. So this was really, I think, the first pathology that we knew. This was from a post-mortem biopsy. So just to stress, this was not a complete autopsy. So not all the organs were looked at grossly and so forth. Biopsies were done from the patient after the patient died. The second paper that came out was also from China, from Tian et al., and that was lobectomies from 2 patients with lung cancer. And in that, what they said was the lobectomies were actually done for cancer, for lung cancer, and there was no suspicion of COVID. But these 2 patients actually developed COVID after. They developed COVID after their lobectomies were done. So they went back and looked at those lobectomies and tried to see were there any clues that those patients had COVID at that time. And they found very non-specific findings that I am not convinced that they actually had anything to do with COVID. What happened in March? Did anything come out? Actually, there was nothing in March at all while people were dying all over the world, except one YouTube video that actually I was asked to put on YouTube by a colleague of mine named Dr. Jared Gardner, who, as usual, had the foresight that people were looking for this information and were hungry for some kind of information on what was killing patients. So I put out a YouTube video on that in March of 2020. There was no other literature from anywhere in the world in pathology. And after a journalist from the New York Times saw this video and reached out to me directly, he was the director of the audiovisual part of the New York Times, and we made a video for the New York Times with him that has now been seen by 1.3 million people worldwide, just on YouTube. So this is much more than that, more than 1.3 million. And even by the beginning of April, we had nothing else except these anecdotal things from us trying to describe what was going on in ARDS, but we didn't know anything about the pathology. So these are the references that first came out from China. So we had 0 complete autopsies from anywhere in the world by early April 2020. This is the New York Times video that came out. It was produced by Joshua Kessel. That came out on April 6th, 2020. And again, there was no literature at that point. And we were just trying to explain what ARDS is and what it means, as I'm going to do with you. So there is a difference between ARDS and diffuse alveolar damage. ARDS, or in Spanish, Síndrome del Distrés Respiratorio Agudo, is the acute respiratory distress syndrome. It's important to understand that this is defined by clinical criteria. Se define por criterios clínicos. In contrast, diffuse alveolar damage, or daño alveolar difuso, is defined by histologic criteria. Se define por criterios histológicos. In other words, DAD is diagnosed by pathologists, not by clinicians. A clinical doctor cannot diagnose, a pulmonologist cannot diagnose DAD. And in the same vein, ARDS cannot be diagnosed by a pathologist because the criteria for ARDS are all clinical or imaging based. I hope that's clear to everybody in the audience. So what are the criteria for ARDS? How does a clinician make this diagnosis? The first is the A. The A is for acute, and that means onset within 1 week of a known clinical insult or new or worsening symptoms. Number 2 is the R, and the R and the D, that means respiratory distress, and that is respiratory failure not explained by heart failure or fluid overload. In other words, if it's heart failure, then it's not ARDS. That has to be a non-heart failure cause. The third thing that has to happen for ARDS is that you have to have hypoxia and low oxygen levels. And finally, you have to have bilateral lung opacities on chest imaging. In other words, instead of the lungs being black on both sides, you get these fluffy white opacities on both sides. And in the most severe cases, both lungs turn completely white, as is shown in this chest X-ray in this image. In this picture, I'm showing you the difference between ARDS and normal. ARDS is on the left side and normal is on the right side. I hope everyone can see the arrows are showing you that ARDS, there's white out of the lung, at least the basal portion of the lung, and in normal, there's almost all the lung is black in color on a chest X-ray. What are the causes of ARDS? I'll run through this in English, but let me turn to the Spanish version of this. Thank you, Irene, for doing this for me. ¿Qué causa el ARDS? There are shock is the most common cause. Next is sepsis / infección. Next is tóxicos inhalados, and the most important there is vaping. Nowadays, we know about vaping, we know about mustard gas, we know about bleach, we know about other toxic inhalants. Then there is fármacos tóxicos or toxic drugs, of which the famous one is amiodarone, and then quimioterapia, which is chemotherapy. The famous one there is bleomycin. That's the most famous one that causes ARDS, but many other chemotherapy drugs can cause ARDS. Then tóxicos ingeridos, then is aspiración. This is my favorite topic, which is aspiration of gastric acid or particulate material and food. But aspiración is a very well-known cause of ARDS, especially in the in stroke victims, in CNS obtunded people. And finally, irradiation or irradiación. So these are the common causes of ARDS that you should know of which infection is a very, very big and important cause of ARDS, including all the, I wouldn't say all, but many of the viruses can cause ARDS, some bacteria can, and even fungal infections. This Venn diagram shows you the relationship between ARDS and COVID-19. So there's a large number of ARDS cases, of which only a few of them are caused by COVID-19. Similarly, there's a large number of COVID-19 cases, of which only a few of them lead to ARDS. And as you all know, many patients with COVID-19 are completely asymptomatic, so that's the right half of the circle. And even of the symptomatic people, most of them will not develop ARDS. So ARDS happens only in a small subset of patients with COVID-19. So I hope you understand that not all ARDS is COVID-19 and not all COVID-19 is ARDS. There's only a small sliver of overlap between these two conditions. Now I want to show you what happens in terms of how does the virus get down to the lung. And this is a very nice animation created by our in-house animators at Cleveland Clinic. It's Mark Sabo. In this animation, these bubbles are actually the aerosol droplets, and those little yellow things are the virus. So this is the SARS-CoV-2 virus. And you'll follow what happens as you inhale these droplets from close contact. So the virus actually goes inside your nasopharynx. It sticks to the back of your nasopharynx and there multiplies. So there's more and more virus. And then it starts going down the respiratory tract, down the trachea, down into the bronchi. And the bronchi then branch left and right on both sides. And the virus keeps going further and further and further down. We know this now from various studies. And at the end, the virus reaches the very lowest part of the respiratory tract. What happens after this? So now this part of it is the lowest part of the bronchus and then the bronchiole, and then it encounters the part of the lung where the air exchange happens, which is the alveoli, which are these fluffy things on this picture. And here you can see an alveolus. This is the wall of the alveolus. This is the center of the alveolus. And these little red structures are the capillaries that bring in the blood that gets oxygenated. So where does the virus come in here? Well, these are the little particles coming in. So I'll stop it for a second here. The very key to understand about diffuse alveolar damage is that these little yellow viral particles cause damage to the epithelial cells in the alveolus, but also to the endothelial cells right here in the small capillaries. So there is diffuse damage both to the epithelial cells as well as to the endothelial cells. So when people pretend like endothelial damage is some sort of unique thing that happens only in COVID, that's completely incorrect, because we have known for many years that diffuse alveolar damage, actually part of diffuse alveolar damage is endothelial damage that is caused by a multitude of agents. So I want to stress here that the hyaline membranes that we see in diffuse alveolar damage occur because the capillaries are being damaged, and then they leak plasma proteins into the alveoli, and then the epithelial cells are being damaged and the debris from them mixes in with that stuff. So what happens is you get these pink structures that form on the inside of the alveolus, and you see how it's getting thick. So these structures here are the hyaline membranes that are made up of the combination of damage to the endothelium and the epithelium. And those hyaline membranes are the hallmark of diffuse alveolar damage. That's what pathologists see and are able to diagnose this entity. So these are the very thick hyaline membranes, and at the end of it, what happens is then you can get super infected with bacteria, and you can get a secondary neutrophilic reaction on top of the diffuse alveolar damage, and this is also seen in COVID-19. So with this, Maria, let's go to question 3, if we can, please. So this is pregunta 3 de la encuesta. ¿En cuál de las siguientes células hallamos el virus SARS-CoV-2 de manera más frecuente? Choice number 1, fibroblastos pulmonares. Choice number 2, neuronas. Choice number 3, células endoteliales. And choice number 4, pneumocitos. So which one of the 4 is it? Which one of these is most infected with SARS-CoV-2? Is it pulmonary fibroblasts? Is it neurons? Is it endothelial cells? Or is it pneumocytes?
Well, people are voting. Let's just give a few seconds, if you mind. You can vote just by pressing the number on your screen.
There's a question in the audience, Lucia.
Absolutely. Do you want me to take it, Jorge? I can answer it.
Yeah.
Yes.
Okay, we can do that. It's just that I'm at the polling, so let me just wait a second if people end voting, and I will give her the microphone.
Yes.
Okay, though we have already finished the question. We have 5 people who voted for choice number 1, 20 people who voted for for option number 3, and 43 people who voted for option number 4. And I will give the microphone to the person who was asking the question. Sorry, I don't remember who was.
Lucia.
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 Does Lucia want to ask the question, or should we go on?
I think that we can continue, Sanjay.
We can continue. Okay, so let's move to the next. La respuesta correcta es pneumocitos. So pneumocytes are the correct answer here. It is actually, it would not be incorrect to say células endotheliales, because there are some papers that have shown infection of the endothelial cells, but as I will show you later in this talk, there's a lot of doubt about the endothelial cells, whether those reports are correct or incorrect. So we are not sure that those reports of endothelial cell infection are actually correct. What we are absolutely sure about is that pneumocytes are infected by SARS-CoV-2, and I'm going to show you some pictures to show you what that looks like. So here is a picture from a publication that we did with Dr. Chris Larson from Arcana Labs, and he used, using some of our material as well as from other collaborators, he used an in situ hybridization study, a chromogenic in situ hybridization for SARS-CoV-2 viruses, and that showed viral particles actually in the type 2 pneumocytes, or in the alveolar pneumocytes, as shown in this picture. So there is absolutely clear proof that pneumocytes are infected by SARS-CoV-2. This was followed by a very nice paper from the CDC by Martinez et al. With Dr. Sherif Zaki, Wunjushi, and other very well-known experts in infectious disease pathology. That paper showed that SARS-CoV-2 could be detected by immunohistochemistry in the upper airways, including extracellularly among the cilia and within the cytoplasm, as well as in the lungs. And they showed this by immunohistochemistry as well as electron microscopy, but they did not see the virus. The CDC authors did not see the virus in heart, they didn't see it in the liver, and they didn't see it in the kidney. So I think this is a really good paper because it is done by a group of people who have expertise in infectious disease pathology as well as electron microscopy. In fact, Dr. Cynthia Goldsmith, who is from Duke University, is an expert in electron microscopy of infectious diseases. Here are some pictures from that paper from Martinez et al. And it shows you, you can see up here in part B, viral particles up in the respiratory cells. You can also see viral particles in the macrophages. And very interestingly, I think Irene will find this, and Jorge both, very interesting, you can see viral particles in the hyaline membranes. In the hyaline membranes when you do immunohistochemistry and in situ hybridization. I find that very fascinating, that there is extracellular virus within the alveoli. And on the right-hand side, you see electron microscopic pictures of the SARS-CoV-2 virus, as shown in this publication. In part A, you see it in the alveolar space. In B, you see it among the ciliated cells of the upper airway. In C, you see it in the type 2 pneumocyte, so that the choice pneumocitos was correct. And D was, you see it in membrane-bound vacuoles. And in part E, you see it in alveolar macrophages. So all of these cells have been shown to contain SARS-CoV-2 virus. Now here's a picture for those of you who are not familiar with the histologic appearance of DAD. You see DAD on the left side and normal on the right side, and you can see how much it thickens the wall of the alveolus, even to get the organizing at the acute phase of DAD. If you look at the organizing phase,
there's a question in the chat.
Yes, of course. Go ahead.
The question is, what type of immunohistochemistry was used?
Yeah, so most people are using an immunohistochemistry for the SARS-CoV-2 spike protein, and there are other forms of immunohistochemistry are also being used. We are using now, or we are trying to develop an in situ hybridization using the nCoV 2019 from ACD, from I think it's called Advanced Cell Diagnostics. So most of them, I think, use the spike protein, but I know that there are other immunohistochemistries also developed. I feel that in general, the in situ hybridization is a better, perhaps more sensitive way, maybe even more specific and easier to read than in situ hybridization. So I feel that that is the better of the two techniques. I prefer in situ hybridization over immunohistochemistry. Is that fair, Jorge? Do you think that's a reasonable answer?
Okay. Yes, thank you, Maria Paz.
All right, thank you, Maria, for that question. So here I'm showing you the late phase, DAD in the late phase or the organizing phase, and you see how thick the alveolar septum is in an organizing DAD. Now you compare it with the normal lung, and you can see if air had to diffuse through this extremely thick alveolus, how much of a difficulty it is to do that. So it really explains nicely why you get hypoxia in these DAD patients and why it leads to ARDS or the acute respiratory distress syndrome. So to summarize, el ARDS es el resultado de una lesión repentina y grave en el pulmón. Cuando se desarrolla el ARDS, los niveles de oxígeno disminuyen y a menudo requiere ventilación para mantener vivos a los pacientes. In other words, you need in ARDS, the oxygen levels fall, and you need ventilation for some patients to maintain their oxygen levels. All right, so with that, I finished part 1 of the talk. Now for part 2, we will talk about our study, which is the first peer-reviewed published report of COVID-19 autopsies in the United States. And in fact, it's the first published report of COVID-19 autopsies in the world outside of China. So the only place that had any reports in the published literature at that time was the 2 Chinese reports that I'd shown you. So, so parte 2, primer informe publicado y revisado por pares de autopsias de COVID-19 en los Estados Unidos. All right, so Maria, we're going to go to the next question, please. That is question 3. Pregunta de encuesta 3. ¿Cuál de los siguientes órganos de encuentra más comúnmente alterado en las autopsias de COVID-19? Choice number 1, cerebro. Choice number 2, corazón. Choice number 3, pulmón. Choice number 4, hígado. So is it the brain, the heart, the lungs, or the liver? Which of these
People are already voting. I'm going to give them just a few seconds, but everyone is voting now.
That's great. Sorry for the bad Spanish, Maria, but I'm trying my best.
Your Spanish is excellent. We are understanding everything you're saying in Spanish.
Okay, great.
Thank you for making the effort to speak in Spanish.
Yes, again, I'd really like to thank Irene for doing this for me and at short notice. That was very, very helpful. And Jorge, thank you for making those corrections. Super, super helpful.
Well, I'm gonna stop the polling now and show the responses. I know people are still voting. Just give me a second. Okay, I think that's it. I will show the responses. Now you can see it.
Yes, so nobody said brain. 2 people said heart, corazón. 71. So is that 71? Is that how you say it? 71
yes.
Pulmón, and those for hígado. So most people got it right. So by far and above, the lung is the most common site of damage in COVID. Of course, there are many papers coming up about various organ sites, but there is a lot of controversy about what degree of inflammation, infection, damage occurs in those sites, and everybody agrees that the main site of damage in COVID-19 is the lungs. So la respuesta correcta es pulmón. All right, so let's go to our paper. So on April 10th, Lisa Barton from the Oklahoma office of the chief medical examiner actually reached out to me with their 2 autopsies and asked me to look at their cases. And together with Edena Stroberg and Eric Duval from their office, we published their reports before anybody else did, at a time when there was nothing else. There were no other complete autopsies in the literature. So this was April 10th, 2020, and it came out in the American Journal of Clinical Pathology. This paper has had an incredible impact, way beyond what I had expected from just 2 cases, and that's because the entire world was at that time very curious to know what was happening in these COVID autopsies. So this paper has now an altmetric of 810. So just for reference, an altmetric shows how much online attention a paper is getting. It's a numeric value, and the normal altmetric for any publication, a normal publication, at least in pathology, the normal altmetric is 0 to 5. And the altmetric for this paper was 810. So you can imagine how much attention this was getting online. It's actually, for the American Journal of Clinical Pathology, that this is the number 2 of all time of all papers that they have been following by altmetric out of nearly 2,800 papers. This paper was also featured in the Scientific American, which you can hear. This is a free podcast available online, and also by NPR, which is National Public Radio in the United States, and was featured on IdeaStream. So there was a lot of impact and attention. And our paper was called COVID-19 Autopsies, Oklahoma, USA. Oklahoma is one of the states in the United States right next to Texas. And the first 3 authors that are listed on the paper were from Oklahoma. Shubha Ghosh is a radiologist who helped us to interpret the radiology, the post-mortem radiology that is featured in these pictures. This technician is actually wearing the garb that was used during performance of these autopsies in Oklahoma. So just to clarify, the autopsies were actually performed in Oklahoma, and I only helped with the interpretation of the lung biopsy specimens and in writing up the paper. The first case in this series was that of a 77-year-old man. Important to say now, these patients were not known to have COVID when they died. So that's very, very important to know. Most cases in the autopsy series that are published nowadays are patients who have with a known diagnosis of COVID, who are diagnosed by an antemortem nasal swab, are known to have COVID, go to the ICU, then expired, and then undergo an autopsy. But these cases are the opposite. They were not known to have COVID beforehand. So the first patient was 77 years old. He presented with fever and chills for 6 days, had a history of hypertension and remote splenectomy, was never tested for COVID beforehand. And then he was so weak that his wife called the 911, and they came to get him. And en route to the hospital, this patient unfortunately passed away. So at no point during life was there a diagnosis of COVID. When he came to the autopsy, they actually did a post-mortem nasopharyngeal swab, and also post-mortem swabs of the lung, and did a post-mortem chest radiograph, which looks like this. And I think everybody can see there's diffuse whiteout of both lungs, diffuse bilateral opacities that are completely wiping out the lung in this unfortunate patient. So the histology in this case showed classic acute phase diffuse alveolar damage, and the black arrows show you the hyaline membranes in this case. I wanted to also point out to you the green arrows, which show completely normal small blood vessels in this lung. So as you keep hearing in the literature, vasculitis, endothelialitis, vascular thrombosis, diffuse pulmonary microthrombosis, you should keep in mind that many autopsies in COVID-19 patients show absolutely no vascular abnormalities whatsoever. And this was the case in this case too, that most of the blood vessels were completely normal. Then there were only rare thrombi in this case. We also showed that inflammation happens in COVID-19 in the bronchi, as shown on the top left panel with the red arrow, and also happens in the mucosa of the bronchi, as shown in the red circles. And the inflammation is mostly lymphocytic, so composed mainly of lymphocytes. We were also the first to show that there was interstitial inflammation composed of lymphocytes, so what we call an interstitial pneumonia, and the cells are mostly T lymphocytes, as I'll show you in the next picture. So we did a little basic immunohistochemistry and showed that most of the lymphocytes were CD3 positive, that's a T cell marker, and of those, there were both CD4 and CD8 positive, but in our cases, most of them were CD8 positive, so more CD8 than CD4. Case 2 of our series was even more interesting in the sense that the etiology was actually difficult to determine here. This patient was a 42-year-old man, so relatively young, who presented first with abdominal pain and then with respiratory symptoms. But this patient had a history of myotonic dystrophy which is known to be a predisposing condition for aspiration pneumonia. Like the other patient, he was never tested for COVID, so we did not know that this patient had COVID prior to his autopsy. He died after a few hours in the hospital. And this patient actually had acute bronchopneumonia, which we found was due to aspiration because we found aspirated food particles and other aspirated matter in his lung. So this patient actually died at least partially of acute bronchopneumonia due to aspiration, and was also found to have cirrhosis due to cirrhosis in his liver. So he had cirrhosis and acute bronchopneumonia due to aspiration, and we did not find diffuse alveolar damage in this lung. So in this patient, our interpretation is that this patient died with COVID. That means he had COVID and he died of something else, rather than of COVID. That means COVID was not really the main cause of death in this case. Now, interestingly, a recent paper from the Mayo Clinic by Anya Roden and colleagues also found the same thing, that aspiration pneumonia is actually fairly common in people who have who have died of COVID-19. So this is a very interesting sort of side note in the story of COVID-19, is that many patients actually have acute bronchopneumonia, and a subset of them actually have evidence of aspiration pneumonia. Now we go to the third part of our talk, which is Parte 3, Otros Estudios de Autopsias COVID-19. And we will talk about some other very good studies that came out 1 month after our study. And that is by Mentor et al. With 21 cases, and Wickman et al. With 12 cases, and Lax et al. With 11 cases. So these were larger series that came out in May 2020 and really have been the landmark studies in COVID-19 as far as autopsies are concerned. Here are the references. And what these autopsies showed was that first of all, it's important to do autopsies during a pandemic. You remember in the early days of these COVID-19, people were saying that it's too dangerous to do autopsies and they shouldn't be done. But from these autopsies in Switzerland and in Hamburg, Germany, and in Graz, Austria, we actually learned a lot of stuff that is now considered bedrock information in COVID-19. What did we find? We found that DAD is very common in fatal COVID-19. So in other words, el DAD es muy común en los casos fatales de COVID-19. So they confirmed our findings. In the Mentor study, they found DAD in the acute phase in 16 cases and in the organizing phase in 8 cases. In the Wickman study, they found DAD in 8 of 12. So 8 de, what is that? 12. And then in the Lax study, they found DAD in 10 of 11 cases. So 10 de 11. So 10 out of 11 cases had, so almost all of the cases had diffuse alveolar damage. In other words, diffuse alveolar damage is one of the most consistent findings in all autopsy studies of COVID-19. DAD, of course, has a long list of etiologies, most of which are identical on histology. So regardless of what the etiology is, they look the same on histologic specimens. El DAD tiene una larga lista de etiologías. La mayoría son idénticas en histología. So the etiologies, as we mentioned before, infección, shock, traumatismo severo, tóxicos inhalados, including vaping or vapeo, aspiración, exacerbación aguda de FPI, and idiopática, which is called acute interstitial pneumonia or AIP. So these are the lists of etiologies of DAD, and they are almost impossible to tell apart from each other on histology. So we usually need some degree of clinical information and lab information to tell these apart. Here I'll show you some pictures. This is DAD in COVID-19 on the left-hand side, and DAD in H1N1. This is a case that I had seen in 2009 on the right-hand side. These are virtually identical. Here is DAD in a case of strongyloidiasis. This is a parasitic infection. You can see the larva on the right-hand side with the black arrow. These are identical to those seen in any other cause of DAD. Here's an example of DAD in histoplasmosis. In disseminated histoplasmosis, you see the hyaline membranes on the left-hand side and the organisms on the right. And here is DAD in lung transplant recipient. This is a fairly common finding in the lung transplant population. On the right-hand side, you see DAD after chemotherapy in a lobectomy specimen. In the organizing phase, one thing I want to mention in this picture is these sort of inclusion bodies are commonly seen in DAD, and they should not be mistaken for viral particles, which I feel some people see this and immediately think that this must be a virus, but these are not. These are just ubiquitin intermediate filaments. DAD, as I mentioned, can also be caused by vaping and by dabbing. This patient died of DAD in the organizing phase. He was dabbing tetrahydrocannabinol, and this is the reference for our paper. The second thing that you should know is that bronchopneumonia, as I mentioned, is a common finding in COVID-19. La bronchopneumonia es común en el COVID-19. In fact, all three papers that I mentioned showed bronchopneumonia in their cases. In the Mentor paper, diffuse in 6 and focal in 4. In the Wickman paper, focal bronchopneumonia in 4 out of 12. And in the Lax paper, bronchopneumonia in 6 cases. So all autopsy series, including the recent Mayo Clinic papers, show a significant proportion of cases have bronchopneumonia. I find this a very interesting finding because bronchopneumonia with neutrophils is usually caused by bacteria, and not all of these cases are positive for bacteria on microbiology. So I'm puzzled. I'm not quite sure why the bronchopneumonia with neutrophils occurs in these cases. Is it just that they are bacterial and we can't find the bacteria, or are they caused by aspiration, or is there some other mechanism? I'm not entirely sure. And finally, thrombosis is a common finding in fatal COVID-19. This is something that we had not seen, but others have seen. So to say it in Spanish, la trombosis es común en los casos fatales de COVID-19. So microthrombos en los capilares alveolares in 5 of 11 cases in the Mentor study, deep vein thrombosis in 7 of 12, and massive pulmonary embolism of 4 of 12 cases in the Wickman study, and thrombosis in all 11 cases in the Lax study. So thrombosis turns out to be a fairly common finding, although not all cases have thrombosis. Many cases do have thrombosis, especially if you look in uncommon sites. So I'm going to show you some pictures. So in these pictures, you can see beautiful pulmonary emboli from the Wickman study, but also, interestingly, thrombosis in the prostatic deep vein plexus, which is a very odd place to get thrombosis, was very common in the Wickman study. Here's a case courtesy of Dr. Charles Leduc and Michel Oud from Canada. They sent me this picture of beautiful arterial thrombosis in a case of COVID-19. And so if you see a case like this, no doubt at all that there is thrombosis in cases like this, but there are other cases that don't have thrombosis. Some cases can be very difficult to tell there is thrombosis because the thrombi are very small and occur in the capillaries. These are called microthrombi. Here's an image courtesy of Dr. Alexander Zankov and Dr. Sambit Mohanty. Even one step further than that are cases that are not clear at all on H&E, but if you did immunohistochemistry, then you would see for immunohistochemistry for fibrin or other ways of finding out thrombi in the small capillaries. Sometimes you will see microthrombi that show up on these studies. So I find that even a more subtle finding and potentially more controversial finding than flat out H&E thrombi. Here's another picture of these little fibrinogen-rich thrombi within the small blood vessels in the lung. Similarly, some studies have shown microthrombi in glomerular capillaries. This is not a very common finding, but has been shown in some studies. You can see these little thrombi in the capillary loops in the glomeruli. And here's another picture sent by Dr. Desiree Marshall. Her series is now published, I think in Lancet, that shows small capillary microthrombi in a subset of cases. I would like to stress here that thrombi in small pulmonary arteries are common findings in DAD, regardless of the etiology. So it is not just COVID that causes thrombi in DAD. This is a well known in textbooks of lung pathology, including by Dr. Katzenstein and by Dr. Nicholson. And there's a very old study from Dr. Tomaszewski from Cleveland that showed thromboemboli in 21 of 22 patients with ARDS. So we have known for many, many years that thrombi occur in DAD cases. We knew that for many years. This is not something new that we have only found out in COVID. Here's a series from Michigan from a group headed by Dr. Jeff Myers that showed thrombi in H1N1. And actually, when they were describing that H1N1, they thought they were showing something unique. But in fact, there was nothing unique about this. And the same finding, the same combination of DAD and thrombosis occurs in H1N1 and occurs in COVID-19. So here's a case with small thrombi in the small pulmonary arteries in the lung. What is your diagnosis? Do you think that this is COVID-19 because it's showing thrombi in the arteries? It might be fair to guess that, but in fact, this is not COVID-19. This is thrombi in a case of H1N1 from 2009. So again, those of us who have seen thrombi in various etiologies of DAD know that this is not at all specific for COVID-19, and this is not something particularly striking about COVID-19 either. It's just the expected finding that you expect to see in patients with diffuse alveolar damage, regardless of cause. So we'll go to the next section, which is otros organos, or other organs, and what people have found. So in the heart, there's a lot of clinical literature that shows fairly large proportions of cases of myocarditis based on questionable imaging studies. But in fact, if you look at autopsy studies, myocarditis is uncommon in COVID-19 cases. As I mentioned, there's some data going to come out soon that is showing that about 15% of cases in well-studied hearts show myocarditis, but it is not common at all. Other findings such as hypertrophy and amyloidosis are actually more common. In the kidneys, it is very controversial whether there is true infection of the kidneys. There is certainly acute tubular injury in many of these cases, but is it caused directly by virus or not? It's not clear yet. One interesting finding is that viral particles which have been reported in tubular epithelium have been challenged by the same CDC authors that I reported before, have challenged that these are actually not viral particles, that they might actually be something else, and I'll show you in a second. Similarly, in the liver, many findings have been reported. We have a manuscript in submission, and a very large liver study just came out in Modern Pathology showing acute hepatitis, congestion, steatosis, lymphocytic infiltrates, cirrhosis, and central vein thrombosis. But to my mind, it's not clear whether these findings are clearly due to COVID or not. In our series, there were some cases that had microthrombi, but they required immunohistochemical staining. So whether liver is truly a target of COVID-19, in my mind at least, is not a settled question. We go to the next part, Parte 5, is la literatura in patología. And let me talk about some interesting papers. So this paper, which is highly cited, came out in the New England Journal of Medicine. And full disclosure, I was one of the reviewers for this paper. I hated it. I thought that it was not a good paper and it was not well written. But it somehow got published, and it came out in the New England Journal of Medicine. It's called Intersusceptive Angiogenesis and SARS-CoV-2 within the cell membrane of the cells. I have to confess, I have no idea what intersusceptive angiogenesis means. In fact, I can challenge you that virtually no other pathologist has ever heard of this term, intersusceptive angiogenesis. But somehow it appeared in the New England Journal of Medicine, and now we are stuck with this term. If you look at the articles, there is very little true pathology in this article. So I'm very, very doubtful of the originality of this paper that came out in the New England Journal, and will doubtless be cited many times in the literature. A much better paper came out in the American Journal of Clinical Pathology, again from our neighbors in Cleveland, showing SARS-CoV-2 viral RNA in the lungs, in the bronchi, in the lymph nodes, and the spleen by RT-PCR on formalin-fixed paraffin-embedded tissue, but no viral RNA in the kidney and very low levels in the liver. So this paper actually supports the contention that kidney and liver are much less affected, if at all, in COVID-19. So here's one of the papers I really like a lot. This is a letter to the editor in Lancet, and this is from the same CDC authors that I mentioned before. And this actually challenges the idea that viral particles are seen in endothelial cells. So they state several papers, the one by Varga, the one by Su and Kisling et al., several papers that have claimed that there are viral particles in endothelial cells and viral particles in other sections. What these experts from CDC say are these are not viral particles, that this is misinterpretation of cross sections of rough endoplasmic reticulum as viral particles, or to say it in Spanish, mala interpretación de secciones transversales del retículo endoplásmico rugoso como partículas virales. In other words, these were not virus. This was rough endoplasmic reticulum. So this is really a big mistake. So in fact, if these people have published these papers and they were really mistaken, this is a very misleading to call this viral particles. I will end with a few future perspectives, things that we are doing in our own research, perspectivas futuras. And this is courtesy of Dr. Lisa Barton, Stroberg, and Duval from Oklahoma. They have donated a lot of tissue to a large number of researchers around the world, including this paper we are doing with Dr. Gisli Jenkins, who is the editor-in-chief of Thorax. This paper that we are doing with machine learning, which has now been submitted for publication, with Dr. Anant Madhapushi, looking at machine learning in COVID-19 and whether we can tell differences between H1N1 and COVID-19 by using quantitative techniques. This paper with Dr. Nima Sharifi is one of my collaborators in Cleveland. He's a basic science researcher and a urologist with a very high degree of expertise in androgen receptors and prostate cancer. Actually is looking at differences in ACE2 receptor expression and other biomarkers, including androgen receptors, between mice and humans, between female mice and male mice, and between COVID-19 and normal lungs. So it's a very, very interesting paper. Hopefully this will get accepted and come out soon. And to end this talk, I'd like to show one very interesting finding that was noticed by Dr. Umar Hatipoglu, one of our ICU doctors, and he noticed that some patients with COVID-19, their endotracheal tubes were getting plugged with mucus and other debris, completely plugged, to the point that the endotracheal tubes had to be exchanged, had to be removed and replaced with another endotracheal tube. And what he did was he took those endotracheal mucus plugs and sent us those materials in pathology. Unfortunately, I had to handle them myself, some of them myself, which was not a very pleasant experience. But this is what those plugs look like grossly. They are basically mucin plugs mixed in with a small degree of necrotic debris, as shown in these pictures, as well as degenerating and dying inflammatory cells. And when we did a phosphotungstic acid hematoxylin, we can actually show that there's only a very small amount of fibrin in here. Most of it is mucin, and it is mixed with dead and dying inflammatory cells. It would be very interesting in the future to see whether SARS-CoV-2 particles are actually present within these mucus plugs, but it is not clear to me why these mucus plugs don't form in the airways but actually form in the endotracheal tubes and plug them up. Hopefully this paper will also be out in publication soon. It just shows a sort of uncommon complication that has the potential to affect therapy in these patients. So, gracias por su atención. Thank you very much for listening to this talk, and I'm happy to answer questions. These are my kids and my chocolate lab. Thank you.
Gorgeous. Thank you, Sanjay, for this excellent presentation, and congratulations because your Spanish is perfect. We want to open a space for questions.
Okay.
So I have one question in the chat from Dr. Magda. She said, what are the pathological findings in patients with history of COVID infection? I guess that she's talking about chronic changes.
Yes, this is a very interesting question that actually we are now writing a manuscript on this because we are starting to see these patients. Jorge, so what we are seeing is we are getting some specimens on patients who have been sick for more than 1 or 2 months, who have been sick for a long time, who have been on a ventilator for a long time, who have been receiving ECMO. As you know that ECMO is sometimes used, extracorporeal membrane oxygenation is used on very sick patients who can't even be kept alive on a ventilator. And we are seeing some patients who have made it out long enough and are sick enough to have received a lung transplant. So we have seen a lung transplant case from a COVID-19 patient. We have seen post-ECMO pathology, and we have seen pathology from patients who have been on a ventilator for more than 1 month. So what we are seeing is fibrosis. The first thing that we are seeing is interstitial fibrosis. The fibrosis is in a pattern that is expected in patients with diffuse alveolar damage, and that converts into a sort of fibrosing NSIP kind of pattern. So there's diffuse interstitial fibrosis. The other thing I have seen is complete infarction of one lung caused by thrombosis, and then overgrowth of that infarcted lung by candida organisms. So this is a post-ECMO finding. I have not seen that reported before, and I'm not sure what causes that other than very severe thrombosis of the pulmonary vasculature. And in the lung transplant recipient, what we found was very severe and diffuse. I won't. Let me rephrase that. Not very severe, but very diffuse interstitial fibrosis throughout the lungs, in a sort of pattern mimicking fibrosing NSIP. So there's absolutely no question that fibrosis does occur in a subset of patients with long-term COVID. And actually, I've even seen a microscopic honeycomb change in 2 of these cases. So you can get fibrosis with microscopic honeycomb change. It does not look like UIP, more like fibrosing NSIP. And it's very important because it suggests that some patients who survive from COVID after being on the ventilator for a long time could potentially have long-lasting complications and fibrosis in their lungs. So hopefully other people will see similar findings. Jorge, does that make sense? And whoever asked it.
Yes,
What, what about, I want to know if you have seen specimens from milder patients, those that maybe are admitted in the hospital and leave the hospital, are not in the ventilator, and then we have had some patients that 1 or 2 months later they appear with infiltrates again. Are you getting this kind of biopsies, or?
We are not, Irene. So I haven't seen any cases. Basically, I haven't seen any transbronchial biopsies or surgical lung biopsies from patients with mild symptoms. Somebody who you might expect would have organizing pneumonia or AFOP. I have not seen that, but I've seen that reported in the literature.
They have. We are getting these kind of specimens, and
what are you seeing? Are you seeing organizing pneumonia?
Organizing pneumonia in most of the patients. Some have more pneumonitis than expected for organizing pneumonia, and very few have had bronchopneumonia. That it's funny because you wonder if it's a new infection of another organism, but no organism is found in these biopsies. And in 2 cases, I've seen lots of eosinophils, but are like 3 months later, and this happens with COVID patients that they sometimes have other things that are not COVID.
Yes, or it could be that yes, it certainly could be that they have other things that are not COVID, but it also could be that the milder forms really are organizing pneumonia, and
organizing pneumonia.
Yeah.
It's a consistent finding. I think it's, but for example, the other day I saw like a severe pneumonitis with granulomas. I think this patient had another thing.
Yes.
Another thing that the patient didn't know, this kind of things.
I find that interesting, the organizing pneumonia and pneumonitis both, because that might explain why there is a response to dexamethasone in those trials, in the clinical trials, because I find it hard to explain why DAD would respond to dexamethasone, but I find it pretty easy to explain why organizing pneumonia would respond. So I wonder if the patients who are responding to dexamethasone might be a milder form of acute lung injury. Maybe they have predominantly organizing pneumonia, and that's why they respond to therapy.
And some of these patients go well home, and the infiltrates appear later. It's, I don't know, there is a lot to find out about COVID.
Yes, definitely. And your point about the bronchopneumonia is also well taken. You know, maybe some of these patients have a neutrophilic pathology for some reason, maybe because of bacterial co-infection. Maybe some of them have drug toxicities. You mean they're being treated with drugs in some instances. They might have drug toxicity. And then, you know, what about the other things that can get superimposed? Maybe some of them have superimposed aspiration. That can also happen in these patients, maybe complicating the picture. Very interesting. The granuloma thing is also very interesting, actually.
Doctora Jacqueline from Bogota, you can open your microphone and ask.
The microphone, it's on the bottom of the screen. Hay como un loguito donde se levanta la mano. Ahí está el logo del micrófono. Si lo quiere imprimir, doctor.
Sanjay, I have a question for you. I've seen a couple of reports with the diagnosis of acute fibrinous and organizing pneumonia.
Yes.
What do you think about that diagnosis in these patients?
Yes, this is a good question, Jorge, because this comes up a lot. In the early days also this came up a lot. So there are two schools of thought with this AFOP, acute fibrinous and organizing pneumonia. One school of thought is that AFOP is an entity of its own, and AFOP has a prognosis that is intermediate between OP and DAD, intermediate between organizing pneumonia and DAD. Some patients do really well and some patients do really badly. Then there's another school of thought is that AFOP is actually not a discrete entity, but is simply the earlier phase of organizing pneumonia in some cases, in which the fibrinous balls have not organized yet into meson bodies. So they behave like organizing pneumonia because they are organizing pneumonia. They're just an earlier form. And also some cases of AFOP are actually hyaline membranes that have fallen into the air spaces. So they look like they're balls of fibrin, but they're actually hyaline membranes. And that's why they do badly, because they are actually diffuse alveolar damage. So that's my view, is that AFOP is not really a discrete entity, but some of them are organizing pneumonia and some of them are DAD. And if you look at it that way, it's not surprising that you would get AFOP in COVID. So I have no doubt that there are patients who get AFOP in COVID. I've seen it myself, fibrinous balls, but I don't think that's a discrete entity. I think that is, in some cases, that is DAD, and in some cases, it is OP. It's not anything special.
I completely agree that by seeing biopsies in transplanted patients, we see after some weeks, like the ball of fibrin, later like the fibroblastic plaque, and later even that this fibroblastic plaque gets a little bit collagenized. And
yes,
I think are different phases, and sometimes in the same biopsy you see the meson body and the ball of fibrin.
Exactly. In fact, Dr. Yusem, you guys probably know this, Irene and Jorge, but Dr. Yusem recently published a cicatricial variant of organizing pneumonia, which is exactly what Irene was talking about right now, is when the ball becomes more collagenized and it looks, but is that a different entity? No, it's just a different stage of the same process. So it goes from fibrinous to fibroblastic to collagenous, but it's all the same entity.
And really, after that paper you mentioned, I checked how many transplants due to fibrosing organizing OP do we have, and we have very few. Organizing pneumonia, as we all know, behaves really well, but in some cases it leads to some fibrosis, and maybe it's the fibrosis we are going to see with COVID. this kind of organizing, or maybe not. I don't know.
Yes.
This it makes me, this question that Jorge made me think about the diagnosis of diffuse alveolar damage, because when we can diagnose diffuse alveolar damage when we see the membranes. We agree in that, but sometimes we see those membranes in not so severe situations as ARDs.
Yes.
Because, for example, in transplant, in ischemia reperfusion injury, that's what. My question is, does diffuse alveolar damage imply that there is a severe situation, or shouldn't we don't or shouldn't we diagnose diffuse alveolar damage anytime we see a membrane, or what?
Yes, I totally understand your question, Irene. I see that too. And in fact, other people have also reported this, even in way back in the, I forget what it, but, in the 20th century, in the 1900, and have reported cases of diffuse alveolar damage that are classic with the hyaline membranes, but they do not have ARDS, or they are focal, so they're only in one lung or in one lobe. So there's focal ARDS. So it's not diffuse DAD, it's only focal. So my explanation for that is this, that the injury that is happening in those alveoli is severe. It is severe injury, but it's not necessarily ARDS. In other words, there are cases of DAD that do not cause the patient to become very sick or go into full-blown ARDS. But I still diagnose that as DAD.
Okay, that was
labeled, I leave that to the clinician. So Irene, you will notice this is the same analogy as between UIP and IPF. I diagnose UIP, but not all UIPs will be IPF clinically, right? So I still diagnose UIP based on the histologic features, knowing that not all of them will have the classic clinical features of IPF. It's the same analogy.
perfect.
Maria Paz, you can open your microphone.
Yes. Hi. Can you hear me?
Hi, Maria.
Yes, perfect.
Hi. Thank you so much, Dr. Sanjay, for your exposition. I'm a huge fan of yours in Twitter. No one knows me here. But anyway, I just had a question for you. We saw on your slides that histologically H1N1 and COVID are pretty much the same, right? Because
Yes.
both have DAD. So what, like, it pretty much comes to the same thing as Irene was saying. Like, what is the difference, or why is it more severe COVID compared with the rest of viruses that causes the same histological pattern, you know?
Yes. Thank you, Maria. I totally understand your question. In fact, that's what people have been wondering from the beginning. Is COVID different than any garden variety viruses that we have known for a long time, including influenza, including H1N1, including MERS, SARS? So the answer is there are two parts to this question. One is epidemiologically, is it the same or different? So clearly, epidemiologically, it's different, right? So, for example, you don't have the same high rate of infectivity and so forth in high rate of infectivity and worldwide transmission and transmission by asymptomatics is very different in COVID than it was in MERS, for example, or in H1N1, right? So that's why H1N1 fizzled out and COVID keeps on going on and on because asymptomatic people transfer it. But when you look at the question from a histologic point of view, and you say, well, in terms of the tissue damage, is there any difference between a patient who dies of H1N1 and a patient who dies of COVID? Actually, the answer is no. They look identical. So there is no difference between how somebody dies of COVID and somebody dies of H1N1. And I don't think you can say that H1N1 is less severe than COVID in that sense. So it also killed a lot of people. I think how H1N1 was different in that you didn't have asymptomatic people with H1N1 going all over the place and transmitting at a high rate like COVID. So the differences are more epidemiologic than pathologic. I don't think pathology is that different. Even the
So
thrombosis, as I've shown you, the thrombosis was seen both in COVID and H1N1. So I don't think there's any difference on that level.
Okay. And a last question, Doc.
Yes.
I was just curious about the clots that you found on the ventilator tubes. Have you ever seen it in another disease like that?
Yes, that is a good question also, Maria. Actually, that's part of why our paper is still in submission, because the ICU doctors, actually, there are two camps there. There's some ICU doctors who say, oh, we see this all the time in ARDS patients, that the tube get clogged and we have to change it. What's so special about this? But in fact, our own data shows that it's not that common for garden variety ARDS endotracheal tubes to get clogged. And so our ICU doctors think that this is happening at a much greater frequency in COVID patients than happens in normal ARDS, from any other cause. Why it happens more in COVID, I'm not sure. Maybe there's something to do with, the leakage of tissue damage and leakage of plasma proteins and the way it mixes with mucin. I'm not sure. I'm just guessing. But our ICU doctors at least feel that this is happening at a higher rate in COVID than in their regular ICU patients. Does that make sense, Maria? Does that answer your question?
Yes, of course. Thank you so much.
Thank you for these questions and for the Twitter following.
No, you're the best. Okay, thank you.
Thank you, Maria. There's a question in the chat. The question is, frequently we see patients with slow recovery after 10 days of dexamethasone, and the control chest CT is informed as pattern suggestive of organizing pneumonia. Would you consider that is necessary a percutaneous lung biopsy to define more days of steroid? Or we could assume that radiological pattern probably would be concordant with the histology of OP?
That's a very good question. I am, again, a little bit biased in the sense that I don't believe in the high accuracy of radiologic diagnosis. I am a pathologist very skeptical of imaging findings. And why I say this is because I see very frequently in my practice where the imaging says one thing and the pathology turns out another one. For example, imaging says something has an organizing pneumonia pattern and the pathology shows DAD, or the imaging says heart failure and the pathology shows DAD, or the imaging says hypersensitivity and the pathology shows smoking related changes. So this happens so commonly in my world, in the interstitial lung disease world, that I'm a little skeptical to accept the radiology as necessarily accurate. Having said this, I'd say if you have classic features of OP, if you have peribronchial, peri-airway consolidation, if you have the classic, airway-centered pathology, if you have something that has partly responded to steroids, I think in a classic situation, it's fairly okay to trust the radiology. But if you get atypical radiologic findings, I think that's the point where biopsy comes into play. Whenever you have atypical radiology, I think you should have a low threshold to get a biopsy, provided the patient can tolerate it, of course. Does that make sense, Jorge?
I think so.
Yes. We have more questions in the chat.
Yeah, of course. I'm happy to take more.
This one. According to histological results, a range of time to contagions after death could be estimated?
So according to what? I'm sorry, what is the time
According
that the body is contagious?
Histological results, a range of time to contagion after death could be estimated?
I'm not sure what that means. Do they mean how long is the body contagious to other people?
Stephanie, are you in the room? You can open your microphone.
I will make her a moderator so she can open her mic. Just give me a second.
Okay, great. Because I'm not
Stephanie,
quite clear.
you can ask now if you want. You just have to open your mic. Stephanie, it's on the bottom of the screen if you want to open your mic. Otherwise, if you want, you can ask the question on the chat or in Spanish. Or
Yeah, maybe one of the moderators can read it for me.
go ahead, Irene. Go ahead.
I think, well, I want another question appeared in my mind related to this is, have you said in how many autopsies you have actually found the proof, the histological proof of the virus? Is that so common?
To find virus in autopsy specimens?
Yes, because my impression, or what is said, is that the patients don't die by the harm that the virus is doing. They die because of the immunological system, or because of the body response.
Oh,
Then I think the
see.
question, Stephanie, is that it's related to if the body is contagious, if there is much virus in the necropsies.
Yes. So let me answer that in a couple of ways. So my first answer is I don't know. Okay, that's the summary. We really don't know how long these bodies are contagious. Couple of points I'd like to make. First of all, I don't know of a single well-documented report so far. Correct me, Irene or Jorge, if you know one. I don't even know of a single well-documented report where somebody, a pathologist or a technician, has acquired COVID from doing an autopsy or from a pathologic specimen. I don't know even one. In fact, early in this COVID pandemic, I think might have been April or May, there was a report, if I'm not mistaken, from Malaysia or Indonesia, where they claimed that a pathologist did an autopsy and a few weeks or days later he became positive, tested positive for COVID. In that report, it was just like a very brief letter with no details provided. There was no timeline. It was not clear why he could not have gotten COVID from somebody else, in the community, from somebody in his family or friends or all of that. So to me, it is not clear necessarily that these bodies are infectious. Now we treat them. It's good to be safe and treat them as if they were infectious. But the other thing I'd mention is just because you get PCR positivity in the lung, and we know that these things are positive by PCR, that doesn't mean that that's viable virus, right? It could be non-viable virus, but still be PCR positive. So in fact, I don't think there's any way by histology to be sure that a body is infectious. And the only way to know would be to do viability studies, actually grow the virus in a culture type of medium. And I don't think we have that evidence yet.
And perfect. Another question is, how long do you think that would take to find to develop fibrosis in post-COVID?
Yeah, here we do have some evidence. I know from looking at autopsies that have happened from, people who have been sick for 7, 10, 14 days, that those patients don't have significant fibrosis. They do get organizing phase of DAD in that degree of time, 2-3 weeks, but they don't get the kind of fibrosis that we see in these, like in the transplant case, for example. So I would say my guess is, from what I've seen, it takes about a month and a half, 2 months, 1.5 to 2 months to develop the first signs of fibrosis, microscopic honeycombing. That would be my guess from what I've seen so far. You have to survive, of course, you know?
Yes.
Yeah. But I do feel strongly that there will be people who have had severe COVID and who will survive, who will have some degree of fibrosis in their lungs. Based on what we are seeing now, there is evidence definitely that fibrosis does occur long term.
And I get CTs from before, because something that comes to my mind when I see severe fibrosis, if patients had it or had some degree of fibrosis before.
Yes, that is a great point, Irene. In fact, that is the point where, you know, early studies that said you can get diffuse alveolar damage, and diffuse alveolar damage turns into honeycomb change and UIP. In fact, the opposite was true. These patients had UIP before, and the diffuse alveolar damage was just bringing them to attention. That's the acute exacerbation of IPF. So yes, you're absolutely right. So before we accept that these patients are actually undergoing fibrosis due to COVID, we need CT scan evidence that they had normal lungs before that. So I'll refer you to, there's a recent paper in the Journal of Clinical Pathology, the same journal where we have our DIP paper. That same journal has a case where the patient had CT scans before COVID because they had therapy for breast cancer. So they were having surveillance CT scan. That CT scan is completely normal. Then they had COVID, and then they have a very, very bad CT scan after that with histological evidence of fibrosis. So that's a report that almost proves.
With honeycombing. Okay.
Yeah. So I hope that what you're saying is taken seriously by future papers that try to show this. Is that people try to prove that it is actually fibrosis due to COVID, is not because of you know, some pre-existing ILD. Great point.
Well, thank you, Sanjay. Thank you very much for your time. Thank you to share your experience with us. This was an extraordinary experience. And thank you, Irene, as well, because you are always with us, supporting our meetings. So thank you both. And thank you to all participants. See you next week in the next session of COVID challenges. And thank you.
Thank you very much, Jorge, Irene, and Maria, and all to everybody who attended and sat through this. Thank you to everybody in Colombia. Love you very much. Take care.
Thank you.
Take care.
Thank you very much. Thank you very much, everyone. And thank you for everyone who joined us. Have a good rest of your afternoon.